but yeah, a problem in their life, and I might say something like, well, was there times when that didn't happen? So kind of an exception question from solution focused, and then I might uh, deconstruct the problem with a narrative type approach, um, or a different problem. So it kind of the integrative or eclectic is what I would call is kind of a is more going where the client is. Of course, then that's overlaid with Rogerian person-centered therapy, so which is kind of building rapport. And so the way I see it is there's all these therapies, and there's a lot of interaction, a lot of intersections, and a lot of similarities. And um, to do one pure cognitive behavioral therapy or family systems, great, but it seems like, in my experience, it's more finding the context of where the client's at. This is again assuming for this class, assuming they've already been assessed, and then working with them on the problem or the situation. So that's kind of integrative therapy, and they have a video on the Canvas or Canopy about that, and I think that's been recognized for a long time. And there is evidence behind all these therapies. I think there's kind of this notion that, hey, kind of evidence-based therapy, and I got to do it this one way. And I think sometimes you can just get boxed into a certain way and kind of have your own agenda, even though just the structure of therapy can be having an agenda in a way. But just the notion that there's this eclectic or integrated approach. So one technique or one approach that is not mentioned in this course is the acceptance and commitment therapy, ACT, and acceptance in commitment therapy is and I just do my spiel on this, but sometimes books titles can say a lot of things. The Worry Trap, I don't know if anybody's read this, but it's kind of the notion that with problems, and finding solutions, or attempting to find solutions to problem and work them, that it's if I just try hard enough and long enough, and just really go at it, then I'm gonna take care of this problem. The approach with acceptance and commitment therapy is assumes that there's going to be problems in life, and there's going to be pain and suffering, and that to fight it unnecessarily only prolongs it, the problem. So it's a notion of stepping back from that problem and accepting it, and committing to make changes with that. A lot of that work is with mindfulness. I'm sure you've heard a lot about mindfulness, oftentimes with breathing, biofeedback type of work as far as relaxation. So if you teach a relaxation response or have them do an app on a relaxation, and they got this spiel out, and that relaxation is kind of integrative. It could be used for solution focused. It could be or a cognitive behavioral or a phobia to learn relaxation when exposed to whatever the fear might be, or PTSD, so that's kind of a tool I look at as far as meditation or a relaxation, giving that relaxation response, to be used in a number of different ways. And for some clients that works really well. Others just have a hard time using it or have trouble committing to it. But with acceptance and commitment therapy, there is a lot of that work, and oftentimes in session too. That's the cool thing, that they really encourage that, to be like therapist led and to work on it in session. It's acceptance commitment therapy is kind of heavy on also on metaphors. The Chinese finger trap metaphor is you can have one of these in yours. Okay. The idea is the harder I pull on this Chinese finger trap, the more it's going to grab and keep me stuck. But if I can loosen up and relax, and this thing's so old it doesn't work, then it would slip off. So metaphors like that. So you stop struggling and you find the solution notion. Another metaphor they have. What was the one? Was kind of interesting. Well, the one about two mountains. If you're climbing up a mountain and your friend's climbing up a mountain, and you have a walkie-talkie, and you're higher up on the mountain, and you can see your friend over on the other mountain, and their trail is real windy, and they're really struggling to get up and they're kind of losing hope because, boy, it just seems like it's going on forever and winds back and forth, and feel like, hey, I'm not making any progress. But you on the second mountain, you're at the top, you can kind of see their progress, and you should go on the walkie-talkie and say, hey, you have made progress. You can see your progress. So that's kind of the metaphor for it may be another metaphor. The one I thought was interesting. The therapist can work with a patient to draw the distinction between words and the seeming power of words and experience. And their example is imagine spitting into a glass and then drinking it, and that elicits disgust, right? So, but they go, yet we drink our spit every day. So those types of metaphors and analogies and things are often you'll see in acceptance and commitment therapy as well, and kind of an Eastern type approach as far as letting go, acceptance, and being able to surrender to the problem, not as far as surrendering or giving up in a not trying kind of way, but the more I hit my head against this, the worse it's going to be. So a lot of those examples, and also kind of looking at your values and kind of looking at committing to taking action and being mindful and in the moment and present, and that again, pain and suffering are part of life. I think for chronic pain sufferers too, with the proliferation of opioids, and then the drawback from that is the non-prescribing them anymore because of the fear of addiction, that has brought more people into pain clinics where they try different methods, and that could be the relaxation, could be acceptance and commitment therapy, as far as working on radical acceptance. That's another term you'll hear in DBT therapy too. Radical, I think it's radical DBT is the technique or program. Anyway, acceptance and acceptance commitment therapy. Stephen Hayes was a big author too. That get out of your mind and into your life. So a lot of different examples and kind of exercises to work in session, given as homework. The videos, sometimes I use, the videos of accepting things, and I'm trying to think of the one. Well, anyway, another example I think is the metaphor of a lure, and a lure for a fish. Sees a fish, bait, It's kind of like, don't take the bait, can you let it go? Can you let it go by and observe that bait go by, that lure, and be okay and feel like, oh man, I could have something to eat, but know or feel or observe. There's a lot of observation with that acceptance commitment therapy. The observation of the feelings and that feelings will pass. And so a lot of that kind of stuff. I know it's not in a lecture form here or anything, but those would be examples of working, of what you would work with the acceptance commitment therapy, and as well as working some of those metaphors or things into. Maybe I've gone through several sessions with cognitive behavioral therapies, looking at distorted thoughts and challenging those thoughts and kind of breaking them down and worked with relaxation, and then the client is continuing to show signs of anxiety symptoms, and so getting them to look at sometimes too much effort or the over effort, the too much trying, and non-acceptance of that feeds into the anxiety. So that's just a brief kind of overview of that. And the other one I was thinking of was motivational interviewing. And I don't know if you remember some of you may be taking this semester, the skills class for social work, where you work on active listening, open-ended questions, attending to the client, accepting where they are, affirming them, paraphrasing. Oh yeah, that sounds really hard, or reflecting feelings, clarifying. And just so I'm clear, I just wondered, you said this or that, summarizing. That's the basis for motivational interviewing, which has kind of been helpful with working with clients who are resistant, who want to make a change. The change process, Prochaska's 5 stages of change. I think it's 5. Pre-contemplation, contemplation, planning, action, change, and then maintenance of change. Those would be, that would be what you'd want to be working with. Maybe some motivational interviewing, where it used to be in the drug and alcohol field, there's a lot of hammering as far as you got to work through the denial and education and addiction, where that wasn't working, and it was building resistance and making it more ineffective. So with motivational interviewing, it's kind of coming up beside somebody, acknowledging them and affirming them, but also trying to evoke change by asking them questions. How would you, what would it look like if you did change? What would that, what are the pros and cons of change? Change talk is kind of what they call it, or I've heard it referred to as that. So with change talk, it's trying to create ambivalence. So I'm a smoker, and I'm not really enjoying it, but I'm pretty addicted. So the question might be, why would you want it to change? And I might be like, well, it'd be helpful that it wouldn't cost so much, and I know it's bad for my health. My clothes wouldn't smell, it would cost less. I have to be outside and smoke. So another question might be, what are some reasons to change? Um, well, I could not have smelly clothes, and I can have a longer life, and so trying to just confirm those things and get him or her thinking about that, and what would it look like if you did change, and how motivated are you to change? I have a thing at work. I forgot to bring it. It's a and maybe I'll share. I'll put it on the cafe too. But it's just a 1 to 10 with blocks, and that little arrow to it's just kind of a scaling visual. So I will have that. So scaling, kind of like, how motivated are you to do this? What would it be like? So maybe do you want some scaling activities, which I think they've talked about in some of the other than solution focused or CBT. But it seems like I'm always saying, on a scale of 1 to 10, what would how would you rate your anger, or what's your motivation, or how did you do with your effort towards not avoiding anxiety-provoking situations this week? So I kind of scale that, document it too. But I mean, it's kind of to get a notion of that. So with motivational interviewing, might be So you'd really want to do that. You'd like to do that, but that's important to you. At 1 out of 10, 10 being most important, 1 being least. How important is that change for you in your life? Well, it's real important. So how about motivation to change? Where would that be? 10 the highest. And so kind of those types of things with scaling be helpful as far as helping them it's kind of eliciting from them how they might want to change, or if they want to change, and what that might look like, how important it is, whether they think they'll do it. So it's kind of eliciting change and planning for it, and kind of going through that. It kind of gets them going from maybe pre-contemplation or even contemplation to taking action and committing to that and changing, and then just having them educated about the change process and how difficult that is, and then also then honoring them in the context of that's really a hard thing to do, and that's cool that you're doing it. I'm glad that you want to do this. It sounds like it really would be helpful for you, your family, and it's hard, and how start to build in plans around the change for that. So powerful tool, and also they've used that a lot as well as trying to reach into primary care practices, and if somebody comes in with or ERs, emergency rooms, just with alcohol and drug problems or situations, then maybe instead of, hey, slap their hands, stop using, and I've seen doctors do that, that they would maybe sit down and have the time to sit down and kind of try to evoke some change, elicit some change from them using that change talk. It's interesting too, because in primary care, I went to my primary care doctor a month ago or so, and they have PHQ-9, a depression screening, which was cool, and an anxiety screening, I think. So more and more that collaboration with doctors' offices or social workers in doctors' offices. Some of you may be working in medical settings already, but that and the notion of trying to help doctors be comfortable with assessing that, and I think I can go on and on about that. But so Prochaska's 5 stages, or the stages change, and MI, and I'm guessing you may have had some of these things too as well, and that's kind of I know there's when I was at the VA they were like evidence-based program, and you have to follow the cookie cutter coursework, and I mean it could be effective, and if one was called cognitive processing therapy, and it was a good structured way to guide clients through what PTSD is, how the symptoms, the signs, what knowledge about that, but then walk them through a cognitive processing guide to challenge their thinking around that, and where they get stuck and get hung up. And even with that, how structured that was, I would have a veteran worried about something, like they had like a truck fall on their friend or something, and was afraid of anything up above. But I was doing cognitive processing therapy with him. He was sitting in the office, and there's this plant up on this file cabinet. So in a way, it was in vivo, it was in place exposure. We could talk about that, but at the same time, I was doing cognitive processing therapy. So I guess the point I'm trying to make is that sometimes there can be this, and you need to, and it's important to be mindful as a therapist to be mindful of the techniques or what you're using. But there's also, I think, this school of thought that you have to use. This was evidence-based. This study showed if you do this exactly this way, then it will show improvement, and often it does. But that you still have to build rapport. You still have to connect with the client where they are, and sometimes other things come into play, and they use different techniques from different theories or approaches. So I hope that wasn't. I hope this video can get uploaded. It's kind of long, but and there's a lot of other examples, and I think we're going to try to have other examples of some therapy, just different kinds, and I might try to do a taping too of some therapy and just put it on the live. I'm thinking I might just do the live session with a video next time and just put it up there. I'm not, just haven't had much luck with this system, but it may be my computer too. I'm using my laptop, but so I think I'll stop here tonight again with the assignments. Try to use the prompts, and that way it's just I know it's kind of cookie cutter, but try to use the prompts the best you can. And with the video, even if you have to exaggerate a technique, oh, Jimmy, you said this has happened a lot and you haven't been able to do this. Is there a time when that didn't happen? If you accentuate things. But just because I've noticed some videos come in where it's maybe a lot of assessment and there's nervousness, and it never really gets to the time amount, but it never really shows techniques, or it's really hard to kind of discern. So that should be like, I think, 2 techniques. So I forget the exact instructions, but manageable. If you have any questions, let me know. Yeah, good discussions. I think everybody's going to do fine. If you are graduating, could you let me know? I think I took a poll before the start of the semester, but I need to know to be able to get those grades in. You guys are doing great. Keep that Canvas, if you still have that access to that. If you want to look at other clips, I think that's pretty good. It's a little dated, but I mean dated as far as the hair or whatever, but some of the glasses and things, but good stuff. I mean, some of this, we think we know the latest and greatest, but it's been around for a while. And I even say, kind of like, well, Freudian psychoanalysts, we don't do that. I mean, people don't do that anymore, and we don't do psychodynamic, but yet it's also in the vernacular. It's also there are parts when you talk about somebody's ego, or their, how they see themselves, or if they're defensive, they have defense mechanisms, or they in denial. That's Freud. So I mean, there's a lot of things that, and realities and truths and philosophies that have been around for a while that are still in play and are very effective and helpful for clients. For me, a big part is connecting and being real with them, being there with them, but then I also need to have some techniques. So it's a combination of that. So, and then the paperwork and documentation and all that stuff. But if you are going to therapy, you'll do fine. It's work, but it's worthwhile work, and I think it's being intentional about helping that person even when you're tired, and trying to be patient, and not always knowing what's going to come out at the end of that session or process. Hopefully what they want to have happen, and it's productive and helpful, but it's I don't know, just kind of a strange profession. So, well, thanks everybody, and it's kind of different not seeing people, but and I thank you for your patience with my technology issues, falling behind my grading, but trust me, you guys will do well in this class, and keep up the good work. I will stop here.